Or I just slipped up.
On the floor?
No, it's.
All right, got a quorum. Good evening, everybody. I'd like to begin the meeting at 6:33. Call the order of the Board of Health. Looks like we do have some public participation this evening. Brenda? Thank you,
Hi.
Brenda.
Hi everyone, my name is Brenda Gazzetta. On July 21st, a total of 34 staff members of the nursing division, some of whom are here today or are listening in, signed a letter of support and concern that was handed to Director Karras. This letter was a result of the compensation study that was completed last month and that has brought to our attention the number of inequities among several employees once it was implemented. Director Karras acknowledged that she had received the letter and sent it via email to our administrator. We have since received an email from Mr. Peter Austin inviting all 34 of us to attend a meeting on August 25th at 8:30 a.m. with himself and Cheryl Chukwu from HR, and we appreciate them taking this time to meet with us. Since our meeting will be during business hours and our time will be limited, we would like to ensure we ask the most pertinent questions. Therefore, we would like to better understand what the chain of command and authority is in making the decisions to correct what we feel are the inequities in the study. Who holds the authority and how do we make sure we are following the proper chain of command? We have brought copies of the letter for all of you to read and would be more than happy to answer any questions you may have regarding our concern. As it was stated in the fiscal meeting last Wednesday, if we can retain just one employee, it would be worth it. That is why we feel comfortable coming to you, and we know that you, along with others, want to do whatever possible to make a positive change. We thank you for your time, and we look forward to hearing from you soon. Thank you.
Thank you, Brenda. Does anyone else have any other comments? Thank you all for that information, and we'll have some discussion on that, I'm sure, in the future. All right, division department updates. Okay, we'll go in order. Director Leon.
We're moving forward with all of our notifications for the ordinance changes. We've sent it out to all of the relevant regulated communities, some business groups, et cetera, the chambers. So far, really, we have received very, very little comment. I've received one. I can't speak for Mary Helen. We have decided to offer one more public meeting at the end of August. I talked to Melissa about it today, just to be sure that people have another opportunity to come in and do that. Lindsay has let me know that people, though, are accessing our website that has all the information with the calendar up there. Several hundred a week, I think, are actually accessing it, so I think we are reaching the right people. I wanted to let you know that we're increasing our online record availability, so we just got our on-site septic and well plans up there, so Lindsay's also going to track for me how many people are accessing that. I think there's a real interest in being able to obtain those 24/7 from home. It's the probably number one document that we have requested. And then I am meeting with IT this Thursday with Susan. Melissa asked us to start the ball rolling on looking for a point of sale system for the Department of Health as part of just a tracking, better tracking for fiscal management, and also just to reduce some of the duplicated services that each of us are doing in terms of receipts, et cetera. So we're going to start the process. And then lastly, I would just say that in environmental health, we continue to have difficulty attracting new staff. Currently, we're at 50% of our field staff. So we're in a position now where we are able to continue to offer all of our mandated and other services, but it is takes a lot of planning and shuffling of staff resources to do it. So that's it for me.
Questions for Ed? I have a question. So how often are you in the field now because of the shortage?
I'm not typically in the field, but I will then go into like review plans and things like that to allow that person to go out in the field. So we've kind of shifted just among our programs, moving staff around that would pick up other responsibilities that they really wouldn't do currently under their job description. But we have to utilize everybody to, get that work accomplished.
I know it's probably an old question, but what are your feelings on why we're not getting applicants? Is it salary?
Well, I wouldn't necessarily say that. I mean, I think it's a number of reasons. I think that we have just recently lost, a couple staff, some who have gone back for, to pursue another career, someone going to the CDC for an internship. Those are just opportunities, so it's going to happen. We have lost staff to other counties, but when we lose staff here to them, they are experiencing the same thing and filling holes because they lost staff as well. So I really think it's a fairly universal thing. We do get job applicants. What we're struggling with is getting job applicants that actually meet the criteria to pursue licensure as an environmental health practitioner, because it is very specific in the criteria we have to meet education-wise to do this.
Is there any institutions that have programs that graduates might segue into?
There are. Northern Illinois University is one. Illinois State is another one. We have staff on in our division now that from those institutions, and we have applicants from those institutions too. But we do then, we're competing with all the other, other departments in the entire region for those same applicants. But we are seeing them, and we're trying to look at some creative ways to possibly, give people opportunities to get to that level, and just try to fill those spaces with people who are interested in environmental health.
Thank you.
I have a question. On that same tack, have we ever pursued something like an internship or something where they work with us for, to cover their schooling, and then there's a contract so they work so many years? This is something that's commonly used in some other fields.
We do not have that option available. But what we do have available is an ability to hire people in that are almost done. And Melissa just helped me with this as an opportunity with one more applicant we're working with now, that to allow them to a period of time to get that, finish their educational requirements and get the credentials that they need to get licensed. So we're pursuing that. So we're looking at every creative way that we can to both attract people and then give them opportunities to succeed here.
Thank you.
Penny, I was wondering, do you work directly with Cheryl, or is that something that you do, Melissa? Or do you have to do those things on your own? How is that partnership with HR in terms of?
When we post for positions and, so we have someone in administration, our staff development coordinator, who would work directly with HR to get those things posted, keep them updated, et cetera.
Thanks.
And then sometimes we're asked by county if we want to push it out on LinkedIn, right? They try to do a good job of promoting any of our open positions, but they're doing it for the whole county, so it sort of rotates between the departments.
Thanks.
Any other questions? Director Barrett?
Thank you. We have sent out signups for training for cultural competency for all staff. The trainings begin in September and they run through November. With staff shortages, we wanted to give 6 to 12 weeks out so people can sign up accordingly and work with others to fill in while they're at training. This is part of a grant, the COVID crisis grant. It's one of the requirements. So, we currently have 70 members signed up, and hopefully we'll get the rest of them. The organizational assessment, which is on the agenda right now, has been completed. The assessment will assist us in determining gaps and areas of focus that we need to really start planning for. It's a core requirement for FAB accreditation, so we wanted to kind of just get a whole 50,000-foot view of what we think we need, where we're excelling, where we may be lacking, and that will all kind of lead into assisting us with strategic planning. Next, the staff competency assessment will be going out to all staff this week. The assessment will assist us in determining trainings, certifications, professional development other needs that exist to further understand where our staffing stands as far as their skills and competency and where we need to fill those gaps in. So this is also a core requirement for FAB accreditation. It'll also lead to the creation of a workforce development plan, and that's going to be part of the strategic plan. So now all these things are starting to go in motion, and as we start the strategic plan, which we will kind of address this evening as well, for mission, vision, and values, all of these things will certainly help us get those goals, objectives, and activities in place much sooner. Future assessments will include an equity assessment, prioritization plans, and those will also feed into the strategic plans. We're also going to be sending out later a second survey to all employees asking them, what training do you feel you need? And there are all these different questions through Mentimeter. So it's everything from beginner Excel to leadership trainings and team building trainings. So it's nice to hear back from them what they feel they would like, and I think that would help them just kind of get that morale together and that, know that we're addressing these needs. So in addition, we are working on an electronic sign policy, the TAS contract, which is our answering service. We've had some issues with them, so we will be working with purchasing to go out to bid to see if we can get another answering service. That's all we got.
Thank you. Any questions for Ann?
Is the cultural competency training, is that virtual or is that an in-person?
It's going to be
event?
virtual, yes.
And how long is it?
It's 3.5 hours. So we have 6 classes going from September through November. We may have some extras in.
Sure. That's all.
Thank you. Director Howell?
So I think I mentioned to you quite a while back our collaborative project that we're doing with the Animal Legal Defense Fund. So we'll be bringing our MOU to you next month. It's going to be about $50,000 in either equipment to do cruelties or to pay either the veterinarians or their practice to handle necropsies and things like that. So once we get that finalized, we'll bring it, I'm sure, next month in September. We also are meeting next month with the chiefs of the police. So all the chiefs have a meeting once a quarter, and we're going to be able to present them with that collaborative because they are part of that. That collaborative is the sheriff's office, state's attorney's office, local veterinarians, and then local law enforcement. So we're going to meet with them on that, and we're also going to meet with them on our ordinance and any changes or questions they have in regarding to enforcing the ordinance or the Animal Control Act or the Animal Welfare Act. We also will be bringing to you next month our 4 vaccination clinics that we'll have in the fall. They'll be between October and November. We just have to get some dates from our veterinarian, and we may bring another veterinarian on to help us with that. We're working on changing those kennel technician positions to animal control officers. As you know, I still have 5 or 6 open positions, and a kennel person is paid $12.50 an hour, so it's very difficult right now to get anybody below about 16. So I think if we are able to change those 2 positions to animal control officers, they can do all of the functions of the building as far as office work, kennel work, and out in the field. So I think that's a better use of our time in those positions. We are seeing an uptick in surrenders still. I think COVID is just having a little bit of a wave here in regards to people either moving, changing jobs, having household changes, whatever it is. We're just seeing a little uptick there on that. But we're still working with all of our rescues to transfer out most of our animals. I'm hoping that we'll have a few more of those positions filled up, and we'll be able to do something in September, mid-September, late September. We have a big thing nationally called Clear the Shelter, which we usually participate in August, but this year we're going to support other rescues who are participating, and then hopefully we'll be able to do something on our own in September. So we're looking forward to that. And then we are still working on 32 microchip scanners that to scan an animal to find out who their owner is. so that each one of the municipalities, law enforcement can have one. So that'll be part of that meeting in September as well. So, that's what I have. We're also still working with Workforce Network and Worldwide on some temporary employment.
Thank you. Adoptions?
We're talking about maybe middle of September, end of September. But it's difficult because you have to train people and have them ready to help out with the adoptions, so.
And then on the job description that you talked about moving from kennel to officer, is there gonna be like a junior officer position? I mean, because do they really, I mean, I don't hate to say this, but I mean, are they really signing up to clean kennels?
I mean, it's a function that officers have always done,
Okay.
helped out in the kennel whenever we needed the help in the kennel, so I don't think it's anything different. This would be more regular.
Okay.
But we would still have a few other people who are designated to the kennel.
I have a question. So with the scanners, is that coming out of that $50,000 grant or the 32?
No, the scanners are coming out of some of our funds, and then we may be asking for some ARPA funds for that.
No, okay. All right.
Right now, we're waiting to get pricing. 32 scanners, if you can think about that, that's 32 chips somewhere.
Mhm.
So we have to find somebody or parse it out where we could end up getting 32.
Oh, okay.
So it's gonna take a little while, I think, to get 32 of them.
Oh, I'm sorry.
But some of them already have them.
Oh, okay, so some police.
A few law enforcements, we've given them, we had this program where we lent them out to them,
Okay.
and I think those are probably getting old too.
Oh, okay. All right.
Which scanners are you looking to get?
You know what, right now we have it out for quote,
Okay.
so I can't say which one. I've asked for, you know, a more durable one, specific price point, so,
And what's the charge for the
yes,
charge?
yes, not batteries.
I don't know, I think there's some, I'll look and let you know, there's, every year, there's grants that are available for that, so I'll see if I can find them.
And they have to be universal, so they have to be able to scan almost any chip, the US, and some of them will scan some foreign chips as well.
Any other questions for Mary Ellen? Go ahead, Lori.
Mary Ellen, maybe you've answered, or we've discussed this before. Is there a conversation about, you mentioned the MOU and the collaboration regarding the Legal Defense Fund. I'm just wondering about adoption. And do you partner with other adoption agencies now that there's been challenges there? And is that something to look at long term, or?
Yeah, we haven't partnered with other adoption agencies. We always try to support them in that, but that's more social media support. So we haven't really delved into that too much.
I think it's kid season now, so it's like crazy.
It's mostly what we have to get.
Yeah, and I think that if they go completely vetted, I think, and you guys have been doing that, it really helps them move them to another organization for adoption. Whether that means neuter, spay, microchip.
Yeah, we don't charge anything for the transfers right now because you're really doing us a great favor. And we are making sure they're pretty much vetted unless they want to take them before it's time to have them vetted.
Director Karas?
So to start off with some good news, we are in medium level, community level for COVID. We hit that last week, going into the back to school season. So we are preparing our back to school guidance. The CDC has released some new guidance and have really kind of backed off on some quarantining, and as well as some changes for the school guidance. Tomorrow we do have a meeting with IDPH regarding the school guidance from them, and from there we'll push out our guide. We pretty much have our guidance ready. We're just kind of waiting to see what the state says, and if they throw any curveballs at us, we'll be ready to edit our guidance and hopefully get it out very soon to our schools, since many of them are starting. We have had no new cases of monkeypox since our first case on 7/16. We do have, with the vaccine, we have received our vaccine. We are vaccinating those that are at high risk or are identified as close contacts. Just got some new orders signed by Dr. Tomas regarding the vaccine. We can now give it intradermal, which takes a smaller dose, so we can get more doses out of the vial than just the one dose of the sub-Q. So that hopefully will help with that shortage of the vaccine for that. as well as they provided guidance on the children. There was an exposure in a daycare center, so initially the vaccine was approved for 18 and older, so we have guidance now and the approval to use it in children who have been exposed. That's really all I have.
You said that was the good news, that was what the bad news.
Well, this is that we're medium.
Thank you. Any questions for Dr. Karen? I will say that in response to everyone's discussion regarding the compensation plan, that we're taking that very seriously, so be patient and hopefully things will meet people's expectations. That's the best we can hope for, because we want to retain people. So I just want to put that out there to you. I appreciate you guys all coming tonight and sharing your concerns, and we do take them very seriously.
On that topic, Director Karras, what's your manpower like now? I mean, we've heard, this is the same stuff that we've continually heard, right? Everybody's heard before.
Yeah, I mean, we're struggling too. We have 6 vacancies, or 7 vacancies, epidemiologists, 2 public health nurses, 2 nutritionists, administrative, breastfeeding peer counselor. So, yeah, it's a struggle, but not, half of the workforce that Patty's experiencing.
The list of vacancies is one of the first things I look at in the packet every month, because it's the thing that's on our mind. And for people that don't know in the room, it is a #1 priority. It's a huge priority for us. It's something we talk about constantly. We're always advocating for it. We don't always have, part of the budget process. I don't know if you want to stay to the later part of it, but we hear you. But I wish we could just, I don't know, speaking for myself at least, wish we could do more. Thank you.
Anyone else for Dr. Karras? Okay, on to the consent agenda. Does anyone have anything you want to throw out for the consent agenda? All right, do we have a motion to approve the consent agenda?
Make a motion.
A second?
Second.
Thank you.
Ms. Parrish?
Yes.
Mr. Clark?
Yes.
Ms. Moravsky?
Yes.
Ms. Herman?
Yes.
Mr. Murphyson?
Yes.
Dr. Ansler?
Yes.
Ms. Gaffney?
Yes. On to Northwestern Medicine disbursements.
Yeah, just to note that now that the 2 previous Board of Health members are no longer here, we did not tease it out this time. If you still want it that way, we can do it, but we felt like there wasn't really a rationale to do it that way anymore, so those disbursements are noted on the disbursement report in the finances.
Are we going to still continue to see them separated out?
Well, that's what I'm saying. If I don't know why there's a reason other than, I think that was the only reason, was because we had 2 members who worked for Northwestern and felt that it needed to be teased out because it was a conflict. So barring no other reason to put it back in or to continue to tease it out, I think we'd rather just roll it back up into the financials with 1 disbursement report.
And
We can always change
and put
it.
it under the consent agenda.
Right, and it actually is in that way, sorry, today.
Oh, got it, okay.
So it is part of the consent agenda today. The disbursement report does show Northwestern disbursements.
Okay, great, thank you. All right, so we don't need to vote on that then? We voted on it. 'cause
Session.
it was-
You voted on it, yes.
Right, okay, thank you.
There's a
Sorry,
separate
she's-
line item in here.
Yeah, and I think we had meant, I think it inadvertently got left on the agenda.
Okay, got it, thank you. Item number 6, contracts and agreements and addendums, and I just need to say nacho-wise,
Nacho.
It's an HO,
Nacho?
but it could be nacho, nacho, potato, potato.
All right.
It's definitely nacho. It's delicious.
Is that you, Susan?
Yes.
Thank you.
So, NACHO, we've gotten an award for our MRC program. Chrissy Wasson applied for this. It is called the Rise for the Response grant, and it is, or award, it's for $50,000. As you can see in your packet with the resolution, we plan on using it for supplies. and equipment, and primarily a temporary employee to help us basically get these things up and running, the software and the training for the MRC program.
All right. Do we?
I'll make a motion to accept the RISE grant from Gotcha.
Second.
Got your answer?
Yes.
Mr. Clark?
Yes.
Mr. Markison?
Yes.
Ms. Carmen?
Yes.
Ms. Parrish?
Yes.
Ms. Morawski?
Yes.
Ms. Gaffney?
Yes. Thank you. All right. Program highlight tonight, we have an IPLAN presentation.
Yep, so we have Megan Hack here and Ryan Sachs who are going to give you the highlights of the IPLAN.
Welcome, thank you.
Thanks, Dave.
All right. We're set. I'm Megan Hack, for those of you that don't know me. I'm the Assistant Director of the Nursing Division on the Community Health section, so I work under Susan. And I've been here for 25 years, so this is my third, even though I've been here 25 years, my third round of doing this Community Health Assessment and the IPLAN. So it's been, I hope you guys found it as riveting as we did. The entire thing is in your packet, so you can read it over. We're just going over the highlights of it all. Okay, so we'll go ahead. Ryan, you want to introduce yourself?
Sure. I'm Ryan Sachs. I'm the Epidemiology Program Coordinator for the Health Program.
Okay, so for those of you that don't know, what is the IPLAN? The IPLAN is a requirement for to be a certified, local certified health department. So we're required to apply for this every 5 years with IDPH. However, that being said, we usually do our community health assessment and our community health plan every 3 years, only because in order for us to complete that whole process, we do share it with the hospital systems because they're also required to do a similar process, and then we share the cost. So then we end up doing this every 3 years, but then our IPLAN every 5. But lucky this worked out with COVID where it kind of aligned together, sort of. So the IPLAN is a combination of the community health assessment, and I'll kind of break those down to explain what they all are. The organizational capacity assessment that Ann had mentioned earlier, so that's also in your packet. The community health plan, and mobilizing for action through planning and partnerships, which some of you may have heard of, is our MAP program, and that's kind of the implementation stage. So, okay, so first we complete the community health assessment. So this was kind of a struggle this round, only because of COVID. So normally this process would take us about a year to complete, but this time it took us a couple, 2.5, I think. It was a struggle. So we did it a little bit differently this year. We had the Healthy Community Study was part of it, and NIU completed that for us. And so that had the different components, which I'll go over. And then we also have the community analysis, which Ryan and his program completed. And then all of that together, they put together.
Yeah, it's the community health assessment. So one thing I did want to note, which is a little different from previous years, is we actually interpreted the study that our contract agency did for us. So where previously we did the community analysis and the community study as separate pieces, they are actually one fully integrated report that we're calling the community health assessment, which is what it always has been. But we are actually interpreting the data from the study, which means you might find things in our report that differ slightly from things in that healthy community study report. That is because we're interpreting it based off of our professional opinion and then using other data in conjunction with it to make the final kind of analysis.
That's what I wanted him to explain. So anyway, I just have to say though, I've been doing this my third round of this, and this, working with his team was phenomenal. It's the best we've had so far, so we're really, really happy to have his team. They were great. Okay, so the Healthy Community Study portion had the community survey, so that was completed by 1,200 residents in our community. They sent out emails to everybody, like 8,000 residents, I think, and then people that did not respond, they did send paper copies to. So there was a combination of paper copies and online surveys that were completed for a total of 1,200. Then there was also a key informant survey. So that was a list of influential people in our community that all work in different public health sectors. So between all the hospital systems and the funding partners, we came up with a list of important people in our community, and that would work on different health initiatives, and then we gave them a list of, I think, 181 people. And of those 181 people, only 76 completed the surveys, which was a little disappointing, but not horrible. And then the last piece of it was the focus groups. So we had 38 members participate in the focus groups. So they did have 3 total focus groups, 2 in English and 1 in Spanish. So, I mean, the participation being that it was during COVID and there was a lot going on in the community was actually pretty good, I think. And then the community analysis, that was, like we said before, was completed by Ryan and his program, and that one uses secondary data sources. And then all of that put together is our community health assessment, which the full report is in your packet. Okay, so what we do is we take our community health assessment, and then we present it to what's called our core team. So we had 5 meetings with the core team, and Ryan and his team put together amazing presentations on the entire assessment. And so we went over all the different health issues, and then all the data to support everything, and everybody sat through 5 very long meetings of a lot of data, but well presented. So we did that, and then we go through a prioritization process, and then we identify priorities, and then our objectives are defined. So I'll go through that. So our prioritization process. So our core team, like I said, participated in those 5 data meetings. And so after that, we presented them with a list of 28 health issues that came out of the entire assessment. And they were charged with looking at, and the full thing is in your IPLAN, but charged at looking at those health issues with different factors, so they had to look at them in different ways. And then we got together in an in-person meeting, and we went through the data, and then we went through what was called the multi-voting technique, which was new to us this year, but I think it worked really well. So what we did is we had all the issues, and everybody was able to vote like on an online system in the same room, and so they were able to vote for what they felt like were the most important health issues. So we ended up only going through 3 rounds to get our final priorities, and those are behavioral health, diabetes, obesity and active living, and access to care. The last round, if you can remember, we did have behavioral health, which we identified more as mental health suicide. Diabetes and obesity and active living did show up in our last round. Also, access to care is new this year. So Ryan's going to just give you a little bit of the data to support why those issues were chosen.
Thank you. I'm going to go through a very high-level overview of the data. I'm not going super specific. There's a lot of other information in the full report, data sources that we didn't pull into this just because we would not have had enough time. It took 5 1 to 2 hour meetings to cover all of it. Also, in the actual IPLAN for the 4 priorities, we do go into more depth in terms of some of the actual numbers as well as some of the disparities we saw in these, which we have disparities for every health issue we have across demographic characteristics and socioeconomic characteristics. So I would encourage you definitely to check those out in that report. I'm not going to go through them today just because in the interest of time, I'm going to stay very high level for this. So I'm going to start going through the behavioral health data. There we go. So the first one, the behavioral health is made up of kind of 3 parts that we combine together. It's mental health, suicide, and substance use. So in the Healthy Communities survey, we asked all the respondents to rank what they thought were the most important health concerns that they thought the county faced. And so it's more of a perception question, not an actual estimate of how much is occurring, but what they think are the most pressing problems. And the mental health and alcohol drug abuse are actually the 2 most pressing problems identified by our community members. And a very similar finding was found by our key informants as well. So for the key informants, instead of asking them to rank all the health concerns at once, they actually did it by different age groups. And for every age group except for those under 5, mental health and substance abuse are also in the top concerns. Actually, for the residents right here, 5 to 44, they're in the top 2 concerns. And then for 45 to 64-year-olds and those aged 65 and older, it's in the top 3, with substance abuse dropping out for that 65 and plus, but mental health still staying. So the community definitely views this as a problem that we need to address in the county. In terms of the actual prevalence, the chart on the left is the actual prevalence estimates. So the community survey, we asked everyone to say whether they had or had not received a diagnosis of a condition of some sort. So mental health conditions in general, every single mental health condition ranked in this list is actually the number 3 most prevalent condition in McHenry County. with the two most prevalent being anxiety and depressive disorders. In terms of, yes?
Sorry, Brian, sorry to interrupt. With the key informants, the 76 key informants that we received responses back from, were those, someone in the organization was tasked with like an anecdotal, or were they looking at like their cases, or did they have numbers to back that up?
So that one was more perception. What we actually did is they wrote in various concerns. Those are actually taking all the write-in responses of the most prevalent concerns mentioned for every single age group, and then categorizing them into various things and then ranking how many people said that. So that was actually a write-in response of what they felt was the most important concern. That was in their professional opinion.
Mm-hmm.
So whether they used their own data or not, we can't really say. That was up to them to decide how they were doing it. But they actually wrote in a lot of different concerns, and those were compiled into that full list.
But we are seeing here that these key partners and the community, they're without fail.
Correct.
Well, thank you.
You're welcome. I should say that this prevalence estimate is for adults only. The study, we did collect some data on children from parents, but because we could not actually weight that data, we can't really use the data for the adolescents from that study. So if you're reading the Healthy Community Study, you will see them mention some information on children. Unfortunately, because we can't actually extrapolate that to apply it to the county as a whole, we chose not to use that, so we're just using the adult information from that. We do use the Illinois Youth Survey for our adolescent data, and you'll see something very similar here for the estimates of depression in the past 12 months. In the 2018 Illinois Youth Survey, 33% and 30% of 10th and 12th graders respectively had a depressive episode in the past 12 months, which was an increase from 2012, which you'll see 28 and 24% from 2012. It is similar to the Illinois measurements, but it is higher than where we were in 2012 for those. In terms of the top hospital discharge codes we had, mental and behavioral health disorders, not including dementia and substance use, which were ranked separately in this particular assessment, that is actually our 4th highest rank for the top hospital discharge codes. And then suicides is not one of the top ranked hospital discharge codes, but this data actually shows how we compare to Illinois, taking a risk-adjusted assessment of that provided to us by Advocate Aurora. For one of their systems called Utopio, and you'll see that we are nearly, actually over 2 times higher, have a 2 times higher rate of suicide-related hospitalizations compared to the state. So incredibly higher than them. So even though it's not one of our most ranked health conditions in terms of the hospitalizations, it is much higher than the state.
Do they rank it by age?
So it's risk-adjusted, so what that means is they take kind of age and sex out of the equation, which allows us to look at that and minus that. So basically what that does, it's kind of a standard way of saying it's not based off the age group they're in, which of course you do see differences by age group for hospitalization rates. So that kind of takes that out of the equation and lets us to look at it kind of a standard way of doing that. So this is kind of the best accurate estimate we have of how much higher we are than the state. I'm going to go through the diabetes next, the diabetes data next. So similar, very prevalent condition. It is ranked 8th in the most prevalent conditions for the county. It is also one of our top hospital discharge codes. It is ranked 7th. And then it is also one of our leading causes of death. It is ranked 8th for the leading causes of death. So also very prevalent problem. It actually are kind of 3 measures of disease morbidity that we use: prevalence estimates, hospitalizations, and deaths. It has one of the highest rankings for all 3 of those. In terms of our obesity and active living data, so this is adult obesity. On the graph on the left, that is any adult who is either overweight or obese. The Henry County estimate is 72%, incredibly high. It is actually statistically higher than both Illinois and the US. So even though they look a little bit less, it's kind of minor, it is actually statistically different, so we do have a higher prevalence of obesity and overweight. Similarly, we also have a higher prevalence of obesity at 38% compared to 32.4 and 31.9. So we do have a higher estimate of adult obesity and overweight in the county. It's a little different for the adolescents. This is data from the Illinois Youth Survey. We actually are very similar to the Illinois data for obesity, which is that bottom, the darkest color on there is the obesity in 10th and 12th graders, 10th on the left, 12th on the right. And we're about the same as we were in 2012. It's only about a 1 to 2% difference, which is kind of negligible in terms of the Illinois Youth Survey data. So for very different trend for youth, where we're actually seeing a much lower rate of obesity. And then the last data we're going to look at is the access to care data. So on the left, we have data from the US Census Bureau, which is data from 2019 and 2014. You can see in that McHenry County had an uninsured percentage for all residents of 5.2%. That was lower than the state and the US for that year. It was also lower than where we were in 2014. Good things, of course. But we see on the graph on the right, which is the percentage of adults who are considered uninsured, and that actually is at 10.3%. This data is post-pandemic, where the other data is pre-pandemic. Now you can't really do an apples-to-apples comparison here because it is two completely different assessments. One is all residents, one is adults. But we do see a much higher rate of uninsured individuals in that 2021 assessment, which could be in part due to that pandemic. Of course, we can't prove that one way or the other. Like I said, it's not an apples-to-apples comparison, but we definitely see a much higher percentage. In terms of those who delayed costs due to care, which is one of our other estimates for access to care, we are incredibly higher than the state and the nation. Again, almost 2 times higher than them in this metric. 19% delayed care due to costs among adults in the 2021 assessment, compared to 10% basically for Illinois and the US. And then the last thing I'm going to show, this is our ratio of residents to provider. What that means is you take the number of residents you have in your population and the number of providers, whether that's physicians, dentists, or mental health providers, and you compare those to each other. That means that a higher ratio is worse. It means we have less providers available for our residents. So you'll see in all 3 of these, we are higher than the Illinois and the US, actually significantly higher in several of them for the most recent years. And you can also see for the ratio of physicians and mental health providers, our rate is actually increasing, meaning it's worsening. So we're actually having less physicians available for our residents. Yeah.
Questions for you? On the insured versus uninsured, was there any teasing out of underinsured, or what the level was for you are insured, but your insurance is so expensive or your deductible is so high that you obviously have delayed care due to cost?
So the assessment only looked at who had insurance, multiple types of insurance, whether that was Medicare, Medicaid, private insurance, or one of the other forms of insurance. It did not tease out whether anyone was underinsured. The delayed care due to cost was a separate question then, asking them, did they delay care due to cost? Did they delay care due to other reasons other than cost? And did they delay taking prescription medicine because of cost, which was quite high, which not unexpected due to the pandemic, especially because it was much harder to get in during the pandemic, but not something we looked at in terms of that. We did look at, NIU looked at how income related to those, and that's one of the disparities they looked at, is how did income affect that, and they definitely did see a disparity in that in most situations.
That's tragic. And the second question, you picked diabetes, but it was 8th among deaths, and why not something above that?
So that is so the actual chosen priorities is what our partners chose together. So in terms of the MCDH, Melissa represented MCDH in that meeting. We also had all the other partners had one person represent each of their agencies, and they chose that based off the data we presented, the priorities that they already have for their organizations. So for example, the hospitals have recently completed their own assessments and also have things that were their priorities. Access to care actually was on both of their lists, which is why that's probably one of our newer things, is because that is actually newly on both of their priorities as well. So that was based off of their own opinions of the data we presented and what they have as a priority for the organization. So it does differ, of course. COVID is another good example. It shows up as one of our highest things for many of these, but that was not chosen as one of the priorities. However, that does not mean something's not going to be worked on. It just means it's not one of the 4 that we're going to use the MAP process right now to tackle.
And Ryan, just for clarification, wasn't one of the criteria in the selection process our ability to?
Yes, I should say that
okay.
too. So in terms of the ranking, we asked them to consider the impact. So how big of an issue it is for the county, kind of the prevalence of it, how much does it occur, the feasibility of addressing the issue. So if something is highly prevalent, but it is very difficult to address, it is not something we would necessarily be able to have a priority for.
Like cancer.
Yes.
Okay, that makes
And then, so one of the other things then too is certain issues that are kind of subsumed by others, disparities, for example. Disparities wasn't chosen as one of the priorities, but it's going to be tackled within each of these priorities because it's a known issue. So that one was not chosen not because it's not super relevant to do, but because it's going to be tackled within the context of the 4 priorities.
Laura, you had a question?
Yeah, some of the statistics are pretty striking when we compare them to all of Illinois. Do we compare our county to similar counties also? Because if we're comparing it to all of Illinois, basically comparing ourselves to Cook County, because about half the population lives in Cook County. It's a much different demographic. It's much wealthier and it's strong middle class. We're pretty rural, pretty low income. So do we compare?
And this assessment
All
we
the
did not.
counties? Okay.
Instead, what we chose to do was to compare ourselves to where we were 5 years ago, where we could, or over 10 years if we have that. So instead of choosing to compare ourselves to what the other counties were doing, we felt it was more relevant to look at how do we compare to our historical data. We used the state and the national data when we were incredibly different from that, but otherwise even that was actually one of our kind of lesser things. We only pulled it in where it was a striking difference, and we mostly focused on how do we compare to the past to show what trend we're moving in.
Yeah, I have one question. So for the uninsured, did the study, sorry, I didn't have a chance to look at the whole thing yet. Did it compare the age of the uninsured? Like, were they mostly, wondering, is it mostly young adults who just got off their parents' insurance, or was it all ages found?
So we looked at that both in the Healthy Community Study, and IU looked at that for our survey respondents. We also looked at that for the U.S. Census Bureau data, so in the Access to Care section, you'll definitely see those. From the U.S. Census Bureau data, from what I can remember, those that are on their parents' insurance and those that are over 65 and therefore can be on one of the, yes, they actually had way higher rates of insurance than those that were in the middle of those age groups. I don't remember exactly what NIU found in their study, but that is one of the graphs in there too. Yes?
I don't know if your study was empowered to look at the why. For example, the depression, where we're so much higher than the state average. Do we have any idea why we are?
Not something that we could tease out with the data we got. We can look at all the demographic data and see where it differs, which might explain some of the why, but not all of the why. But that is not something that this kind of study would be able to tease apart, especially because we asked questions on so many different health conditions that to go into more detail on any single one would have been, it was already multiple pages of, it took, community members probably like 30 minutes at least to complete the full assessment. It's not something we could tease out in this one. The kind of best guess we have is kind of some of those differences by different demographic groups, which explains part of it, like I said, not all of it. Yeah.
Just one follow-up, especially on the depression statistics. How much do you think COVID may have impacted and social isolation?
So in terms of our youth data, that actually is before COVID, so COVID would bear no influence on that. Unfortunately, we couldn't use the assessment for youth from 2020 because only one school filled it out for the county during that year, which means it does not represent the county at all. The 2022 assessment was much better, so we'll actually be able to do some follow-up on that for the youth data. In terms of the data from the Healthy Community Study for adults, we didn't do a historical comparison for that because this was a new version of the methodology. We did what is called a random sample, meaning we choose a subset of our population and they represent the whole population. Different than what we used to do, which was to take anyone who was willing to fill out the survey. This actually gives us estimates that better represent the county, at least in theory. And so we don't have a pre and post COVID comparison for that one right now, but all the data for Illinois and for Illinois and the US for that particular one is from also during the pandemic. So that is a kind of same comparison both after the pandemic or during the pandemic. Some measures in the study, because we don't have data from Illinois or the US, are actually pre and post-pandemic, and that is some of the difference is because of that. We tried to kind of draw attention to that where we could. But this is not one of those cases for that. So those differences are both after the pandemic, so we don't actually know how much our rate of depression actually increased during the pandemic.
I was one of the ones that got the survey. I don't recall, was there an income level on that survey?
So it wasn't pure income. We actually did, we took the size of the household plus the annual income and used that to make a measure. So it was two separate questions that were used to determine low income and mid and high income. So you probably wouldn't have seen something specifically kind of like income like that. It would have asked, I don't remember the exact question, it is in the Healthy Community Study near the end of that, you can see all of them. It would have asked in like groupings what your approximate income was, and those were used then to make income grouping categories based off the size of the household.
The reason I was asking is I don't know if you did a correlation by income based on the top four categories, depression and that, if you notice any trend based on income level.
Yeah, so for each one of those conditions, they did look at the different incomes. There's no comparison between the different prevalence estimates. Actually, this study design methodology, it was not kind of a comparison you could do with the type of statistical test they were using. There are some other methods that could kind of tease that out, but it'd be a little bit more kind of harder to do and not necessarily something that we would consider kind of valid to use in this case. But that is in there for every single one of those groupings. There should be prevalence estimates by all the different demographic characteristics, including income, and those should be on in the Healthy Community Study report or our Community Health Assessment report.
And those are in the appendices.
Yes.
Any other questions? Thank you very much.
Oh wait, we're going to talk We're real quick. So we do have, so what we're going to do moving forward is we do have a community presentation scheduled at NCC, which we have not started advertising yet because I just secured the date. But so we will invite everyone in the community to hear all the data and to hear about the priorities in our community. And at that time, we invite people to be part of the process, the implementation process. And so that's kind of where we pull in all these different sectors. So for those of you that aren't familiar with MAP, that's what we have MAP. We follow the MAP framework, which is a NACHO framework. And we've been doing this since 2006. So this has been ongoing for a lot of years. And a lot of our MAP groups are very strong and have partners that have stuck around for a very long time. So our partnerships in the community are excellent. And we always want new partners depending on what strategies we're addressing. So what we'll do is we'll form, after our community presentation, we'll form new MAP work groups. Some of them will be existing, like we do have an active communities work group already that's very strong and has really good partnerships and are moving good initiatives forward. We do have an obesity work group that's ongoing that we will continue, but we'll pull new partners in depending on what strategies they choose for the next 3 to 5 years. But we do have objectives in your IPLAN that do align with Healthy People 2030 because that was one of the requirements of the IPLAN is that we do align those. So the MAP work groups will work off those objectives, but we'll do strategies based on how objectives that they choose locally. And so that will depend on the partners they pull in and how they feel they're going to address these issues. So that is upcoming, and we'd be happy to bring those once the MAP groups get going to give you guys updates on how that's going. We do have the separate work groups, but every year we have an annual MAP meeting where we bring all the work groups together and we talk about our objectives and how things are moving forward and what their plan is for the next few years. So just wanted you guys to be aware of that. And then I think I already said the strategies local strategies will be defined by our work groups. So that's kind of the plan moving forward. So more to come on that. So any other questions?
Will the IPLAN be printed in pamphlet form so an interested person could obtain a copy and
I mean, we could print it. We will have it all available on our website. Every piece of this will be available for people to have. But in the past, I mean, if somebody had requested it, we could have it printed.
We are also going to be looking at making this kind of more palatable for the public. A 91-page report plus a 100-page report is not the easiest thing to read. So we're looking at ways we can use infographics and other things like our website to make this information easier to understand and read and to figure out what we did. So stay tuned for that, but that's kind of one of our next steps too.
It's in our plan.
Would that include, when you're saying that, make it more palatable or easier to digest, like a summary, like, these are, I mean,
Yes.
to me, this is stark. I mean, this is frightening, that there are some good things, and they talk about strengths of the county in there, but you have a number of different people, all the people we surveyed, the key partners, they align that this is an issue. And a lot of this comes back to the same stuff that we've seen since COVID. It's like you have employment tied to healthcare, you lose your employment, then you lose your healthcare, now you don't get care. We have less providers in the county. I mean, what becomes the action then to correct some of these? Part of it, in my opinion, is communication. It's like putting this front and center, like, this is a huge problem. We need to do something, like, as the county, as the partners. I mean, we investigated all this. You guys put a ton of effort into this. My number one concern is that we do these and it just gets lost, like, in the noise, so.
Too, when you think about the provider ratios, if you go into the city, you have so many doctors because there are all these specialists and there's all these, and people come from here to go there when they have something specific or just because of their preference. So I think if you were to look at almost any rural community, I think we probably wouldn't be too far off, or there would be a disparity between the ratios between rural and urban communities, because when you compare it to the whole, Cook County is half of the state.
Right. And I agree with that, and I fully understand. This is one of the rural challenges, but it's also why we have rural initiatives to help try and leverage and fill some of those gaps. I mean, like physicians going out and get additional funding, like residency in schools, and there's other things to encourage you. There's an entire rural medicine program at Rockford, the medical school at Rockford, and it's just like too little too late. I mean, my big thing is about the communication. It's like, this is a problem. People are killing themselves. People are, have problems. Sorry.
No, I agree, and so I don't want to jump the gun, but I'm going to, and as Chair of Public Health and Community Services of the County Board, I'd like to invite you both to our meeting September 1st. So Melissa and I can work together to hopefully get you on the agenda, because I'd like the committee, the Public Health and Community Services Committee, to get this information, because I agree, we have to get it out, we have to share it. The committee has been asking for quite some time about a variety of information, and Melissa and directors have been coming to us and talking to us about it, but I think this would be great information for the committee to have as well. Melissa, you were probably already planning on that, so I just wanted to articulate it out into the universe. So thank you very much for your presentation, and I look forward to seeing and hearing more about it in the future.
Very good presentation, thank you.
But it doesn't.
Okay. All right, new and unfinished business, mission, vision, and values approval.
All right, so as I touched on earlier, in early June, we had sent to the staff and the Board of Health members a survey defining the department's mission, vision, and values. We had not had this done since 2001 in the strategic plan. 49 people began the survey, but now respondents completed each section. And so the results were that we were able to get the 5 top ranked values. We actually have 10 of them. That's something we kind of want to discuss and touch on to see what your direction is as far as those. I will go through what the current mission, vision, and values were. So the current mission statement was to prevent disease, promote and protect the health and safety within McHenry County. This shall be accomplished by investigating, assessing, and implementing solutions to health and safety needs through collaborative community involvement, education, and data collection. The proposed new mission statement: to protect and promote the health, safety, and well-being of those who live, learn, work, and play in McHenry County. The vision statement, which is from the 2001 strategic plan, was by 2010, the McHenry County Department of Health shall be a recognized leader in the promotion and advancement of health and people within the county, health of the people in the county. The proposed mission or vision, and we never really had one, is an integrated public health system that supports health and well-being for all. And so again, on the last page of the memo that went out to everyone are the values in the order that they were selected by everyone that took the survey. So the top 5 are respect, trust, accountability, integrity, and teamwork. We also have leadership, transparency, collaboration, health, equity, excellence, diversity, and inclusivity, God bless you, and innovation. So, and note that the ones with the asterisks by them is listed. It's a McHenry County government value too within their strategic plan. So that's what we have, and that's what we're presenting. You know, the values, there were 49 votes. The vision statement was 47 votes. The mission statement had 45 votes. So those are your top mission, vision, and values. So basically what we're asking is the values, do you want to go just with the top 5? We don't want to kind of convolute anything. Is there anything else that you believe should be ranked higher or included in our strategic plan?
I think the health equity thing might be moved in.
I'm sorry, I couldn't hear you.
And the health equity might be moved up just because of the results of this data that they presented. There's a huge problem with access to care and access to appropriate care. For example, psychology and psychiatry.
I like that thought, and especially because I was looking at the values, and I feel like there's actually 6 in there: respect, integrity, trust, accountability, teamwork, and leadership. But I felt like integrity and accountability kind of go together. I know that the county likes that; they really like accountability. But equity is probably a very important aspect. We're a little bit different from the rest of the county in that we're, we need to be focused on the well-being, not just the health. I like Juliana's thought.
Any other comments?
So what I'm hearing is the direction is to move health equity up there. Do you want to have the top 6 and have health equity within there? Or do you want to move health equity to a different number 1, number 2, number 3?
Yeah, so are we, if we're only picking top ones, it means we're leaving off
Or do you want
others,
all
or
of
do
them
you
within
want
the
all of
plan?
them? In which case, the order is not as important if we're saying all of these things are.
So to make sure I understand you, you're saying the people voted for those top ones, but all of the ones that we've come to conclude are the 10 in that list. I guess one of my concerns with the previous, even if, as an example, the mission statement and the vision statement, is they were long, right? They were like, it should be, in my opinion, things should be simpler. It's just like, look, you care about people, or you don't need to put all these.
I think the proposed ones were shortened significantly.
Yes, right.
Yes, which I
Oh,
like. I'm just
okay.
saying, as an example, 10 of them is a lot also.
It is.
So I think I would prefer to pare them down as well. I think kind of being on the spot and saying, hey, there's a gun to your head, pick 6 of them. I'm going to struggle. Terrible choice words.
No, I brought rubbish, so
Yeah, exactly.
phrases we gotta get out of our vernacular.
Can you remind us how many people participated in this ranking?
49 people began the survey, but not all of them completed it. There were 49 votes for the top 5 top ranked values. That's what we're talking about now, 49 votes. The vision statement had 47 votes. And the mission statement was 45 votes.
Out of how many potential?
109 at the time.
So it was all staff and Board of Health members.
So do you want to go through and force rank them?
I believe that we should let the process run its course.
I think
That
so
we
too.
shouldn't be amending it significantly. If this is what the group of employees and others have ranked, and unless there is some language that is objectionable to any one of the board members, we should support the process that was undertaken.
I would agree, Joe. Mr. Clark? I would agree.
Anyone else have any other input?
I agree with that. I mean, if there is a process, but I also agree with Juliana.
Mm-hmm.
If I was gonna swap one of them, I'd swap accountability for health equity then.
Another potential option is, well, I think there's lots of options, but one could be that by reference to the county values, we could adopt those because they're already part of the county. They overlap, and then look at the other ones potentially. It makes for long, if we're going to incorporate them into all and reference them and try to integrate them across our programs to make sure that we are reflecting the values, right, in what we do, then all of them become a little bit challenging. I too struggled with the fact that health equity did not make the list, because I feel very strongly that that is something that I believe we do, but putting it out there I think is also really important. Now, we could potentially fold that in some other way, that across kind of what Megan and Ryan alluded to, that despite health equity was not something that was selected in the ranking, it is something that can be infused in everything that we do, and we can make sure that we communicate that effectively.
And I guess to your point, Melissa, isn't that, when I have navigated mission and vision statement revisions and things like that, that vision is what do we aspire to be?
Right.
And, that health equity, we strive to assure all people will have just and fair opportunity to be as healthy as possible. Seems to me, maybe another way to be saying, or addition to, and I don't want to get into, because now I'm contradicting what I just agreed with Mr. Clark about the process, but I think that, and I don't want to spend hours, because I've also been involved in hours and days-long
Sure.
wordsmithing,
Right.
so that's not my intention. But I agree with, this idea around health equity, and does that, potentially become part of the vision. So I don't want to throw a wrench into the process, but I hear what you're saying,
Right.
that really is who we are, that's what we aspire, even if we may never get there because of so many other variables out of our control. But that's what.
Yeah, and we could, I respect the comments too about the process, but that's also why, I cannot remember if equity was one, so there were several options in terms of proposed vision statements, but it could be amended to say an integrated public health system that supports health, equity, and well-being for all. Something as simple as that weaves in the equity as this overarching vision of how we, want our world to be.
I would suggest that the topic health equity is covered at a higher standard in the mission statement and vision statement, when we reference that for all that are participating in living, playing, working in McHenry County, for all. That is inclusive to everybody.
So you see it that it's already embedded in those statements without
Yeah.
actually saying equity, is what I hear you saying. You know, the other thing is that we don't have to wait 20 years to revisit this, and so, you know, so as not to get bogged down, make a decision tonight about those values, and then we would revisit them much more frequently than we have recently.
Melissa, what's the process? Does this then, all of this come to PHCS and then to the county board, or does this stop
I don't
here?
think so.
It stops here?
I would think it stays here.
Yeah, okay. Which makes
It would
sense.
get folded, you know, it would get woven into the strategic plan,
Yeah,
and then, you know, as we revisit the strategic plan periodically, we would revisit, you know, I've seen some of the documentations where, internal documentation of the mission, you know, we have reviewed the mission again and again and again, it just didn't necessarily change, right? And so there would be opportunities for us to make those revisions.
yeah, and I'm not suggesting it has to come our way, I just didn't know it was, you know, that I knew around here, so.
I mean, not that I know of.
Okay, yeah, and that's fine, we don't need to do any more wordsmithing there.
Looking for a motion, or are you just looking for thoughts? 'Cause-
Well, we would like a motion and approval of the mission, vision, and values.
I'll make a motion to approve the proposed mission statement and the proposed vision that are aforementioned.
We have a second?
Second.
Mr. Clark?
Yes?
Ms. Morawski?
Yes.
Dr. Amsler?
Yes.
Ms. Parrish?
Yes.
Ms. Carmen?
Yes.
Mr. Markison?
Yes.
Ms. Gaffney?
Yes.
I'll make a motion to approve the values, the top 6 values with the change of accountability swap for health equity. That'll be respect, integrity, trust, health equity, teamwork, and leadership.
Can we discuss that?
Yeah. Also, we'll need a second,
We'll
and then
give it a second.
we'll have a second and wait for
You can
discussion.
let it,
Second.
let it die on the vine.
Right. All right, we have a discussion. Lori?
So, I'm not necessarily opposed to it. I guess when I look at the values, and hearing, the variety of conversations that have happened at other meetings, you know, that the respect, integrity, trust, accountability, teamwork, and leadership came from those, you know, 49 votes. Those are things that I've heard, a lot about in the last several months, and so I think to bring them out and name them and to be able to have conversations about them, I think I'd stick with those 6.
So if there are 49 respondents that completed, right, and they could select from any 10 of these?
Yep, they ranked them any which way. So if
So
they
were there
ranked,
people that could have chosen integrity? They looked at, because the way I'm looking at it, I look at integrity and accountability, I'm reading the 2 statements that are next to them, and I would put integrity as above accountability. I think it kind of encompasses it. But I could see other people coming through and just saying, they look at the 2 and they chose accountability. And then maybe those ones, I'm not saying, what I'm getting at is, without knowing how the process was gonna shake out, I kind of wonder if those are so similar that people selected them. Like, they didn't choose both of them, they just split them down the middle. Like, out of the 49 people, you know, 24 of them said
one is
integrity and 25 of them chose accountability, then you'd be there, they look like they're both winners. I don't know, that's my thought, I just think they're so similar. I think there's legitimate concerns from Juliana. I think we just saw a presentation about a big portion of our county that's,
Well, can we combine the two into one under accountability? Can we do it with integrity? Or vice versa? I mean, it's really
As far as
easy to
I
add one to the
read it,
end
it's the
of
same thing.
another one.
If you have integrity, then you're accountable. If you don't have integrity, or if you're not accountable, then you don't have integrity to your job. I mean, I
So-
view it as the same thing.
So what
Sure.
I'm thinking is if we take personal responsibility for achieving our objectives, we ask for help, admit our mistake, put things right, and we do it with integrity.
yeah, I don't think it, I'm not sure people are gonna see the value statement there, they're just gonna see the value.
No, we
Those
would
are
have the
defined.
statements, because I think that was, like with the ISC report, and there were no definitions, right? So people were able to rank them, but we felt like we had to add definitions because everybody could be operating off a different definition. Whether these are right or wrong definitions, right? That is what got presented. Because otherwise we don't really, how are we defining that? What does it look like?
The survey that was done was easy to understand, it was easy to fill out. It was kind of a forced choice. You rank them, boom, 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 boom. And this is the results of it. I don't know, I didn't write down how I filled it out, but I would have guessed that some of mine aren't in the top 5 or 6. And I'm okay with that. If the group wanted it this way, majority said this is the way we should set our guidance, and that's the way we should go.
What was the pool of people?
At the time that we sent it out, how many people? Ann just said maybe it was 100.
It went out to 109, I think, at the time.
And the pool was?
It's us and staff.
And staff. So my thought is that dealing, as we have in the past couple of years with transition and new people and everything else, that accountability and integrity were front and foremost at the time when we had some issues going on and maybe some carryover to experience. And so, to me, I get a message that integrity was lacking, if that is high up on there because of past issues, possibly. And so, that's something I feel that as a board, it should be the goal statement. I mean, that should not be something that we have to aspire to. It would be something that we must do. I mean, to give people a choice of telling us whether we're have good integrity when we're looking out for their best interests, it just seems to be a little bit ingenuous. To ask them to say to have integrity. I hope that this board respects the staff enough that we have integrity and that we can continue to improve and show that we do. And I know that's an important function, but I'm not sure if it came about because of issues of in the past. And so integrity to everybody else was important. And I hope that going forward, they see that we're paying attention and doing the things we're supposed to do. But I'm just concerned it was tainted by some issues that were going on in the past that people were picking up because that was a sore subject. I can't speak to that. So I guess I would hope that we all as a board deal with things with the most intentions of making this the best workplace and environment for staff. I just think having to state that is like, it's a terrible thing to have to say, that we need to have integrity for what we're doing. That's all, that's just my comment. I mean, I think we should be genuine and have the highest respect for our staff and do things with integrity. I mean, that, as a board, we're challenged with that every day. So, I don't know, I think that's the overall premise of what everything that we do is we do it with integrity. So to put it down on paper, it almost seems like we're not.
Well, I think if you look at other value statements by other organizations, I would say a lot of these words, I can't think of one that's on here that doesn't exist in other organizations, right? We looked at a lot of examples, including what ISC had done and part of our SWOT analysis and things like that. So I don't know, sometimes it's important that you put it down, right? So that, I mean, I hear what you're saying, but I think it's also really important that it is stated. And again, values may change over time, and I do want to say, so even if we pick the top 6, right? Because I hear part of the room saying, respect the process, that's what people selected. It, by no means, does not exclude us from collaborating, being transparent, health equity, excellence, right? All those things are still going to happen.
Yeah, kind of have to
What's
laugh
the
because
motion?
you feel like
motion.
you almost have to codify everything nowadays because of the way we've learned.
I think
They're not codified.
words have power, they have value.
Yeah.
There's a reason we're looking at this. There's a reason why they've, spent time and effort on this.
Right.
But,
But should that-
Mr. Clark's words are well received, that it wasn't, things may have changed. I think that your point is very good also. But,
Right.
but it was based on predominantly
But this is,
the votes of our staff. They
Right.
definitely outnumber
Yeah.
us.
But shouldn't our mission statement then accomplish the same thing? Shouldn't our mission statement say that we do everything with integrity and it covers everything? Shouldn't we add that to our mission statement?
We should be doing everything with respect, with trust,
Yeah.
accountability,
It just
integrity,
makes the
with
mission
teamwork, with
statement-
leadership, transparency.
Yeah. A challenge to, I think, at least from my perspective, right, that vision statement, they should be things that each of us can roll off our tongue just like that. We're in an elevator, we should be able to say what our mission is, what our vision is, right, and the basic values. We should all be able to do that. The longer you make it, it just gets really difficult and it sort of loses, and people are more likely to get it wrong. And by wrong, I just mean those words are powerful, right? What is our vision? What is our mission? So that we can just continuously repeat it and know whether or not we're doing it, following it.
Mr. Clark, what is the, can I amend the motion I already have on? Do I need another motion to amend my motion?
Did you get a second?
She did.
Yeah, that was second.
It hasn't been voted on.
Right, we're in discussion.
Well,
I could retract it, I could amend it.
you can retract it or someone else can amend it.
Kyle, would you be willing to amend your motion to add the equality, is that
Health equity.
health equity? So we actually have a 6.
Will be
I don't
7.
think that will be overwhelming for anyone.
I would be amenable to amend it.
Your original
An
motion
odd number
had-
is good
Right.
for those who like odd
Right.
numbers.
My initial motion was to replace accountability with health equity, leaving in place respect, integrity, trust, health equity, teamwork, and leadership. But I will amend my motion to accept the 7 top ranked values of respect, integrity, trust, accountability, teamwork, leadership, and health equity.
I'll second the amendment.
Any further discussion?
You have to have a vote on the amendment, and then vote on the main motion as amended, if the amendment passes.
Okay. Darlene, can we vote? Do we have a second on the?
Amendment I did.
Okay.
Joe did.
Okay. Ms. Parrish?
Yes.
Dr. Amsler?
Yes.
Mr. Markison?
Yes.
Ms. Borowski?
Yes.
Mr. Clark?
Yes?
Ms. Carmen?
Yes.
Ms. Gaffney?
Yes. Now, do we have a motion to accept the amended?
It's already on.
It's still on the table, it's now amended.
So now the vote is on the main motion as amended.
As amended. My spokesperson.
Where's the other vote?
Correct.
Okay, I'm sorry, I didn't get,
So we're voting on the amended motion made by Con.
okay. And who made the motion?
Initially,
Clark?
the amendment was myself, followed by Mr. Clark.
Mhm.
The initial motion was myself, followed by Dr. Amsler. So now we are voting on the total amended to accept the values of respect, integrity, trust, accountability, teamwork, leadership, and multi-faith.
Okay.
So,
Okay.
Like phone number.
it says 5 on it, but there's 6 listed.
Right.
So who is making the motion on that? You?
I did.
You did, okay.
Dr. Amsler second.
Okay, all right, I'm sorry.
That's all right.
You're good.
It gets confusing.
That's why I look at Joe.
Dr. Amsler?
Yes.
Ms. Borowski?
Yes.
Mr. Markison?
Yes.
Ms. Carmen?
Yes.
Mr. Clark?
Yes.
Ms. Parrish?
Yes.
Ms. Gaffney?
Yes. Okay, budget recommendation.
Oh, 8B,
We-
board of assessment.
Oh, sorry, yeah. Organizational assessment approval.
Yes, so, this is part of also the certification process. Megan had that on the slides. So, I don't, given time, I don't wanna go through everything. We summarized it, but the areas where, a couple areas that we scored the lowest were under section 5, which was developing policies and plans, and under there was really strategic planning, right, because we still have that outstanding, and workforce development. Those were 2 topical areas within that where we scored lower. Some of that has to do with not having formal written plans in place and competent assessment. That is supposed to be something that is part of what is done throughout workforce on a routine basis. We are working on that now. And things that weren't done department-wide, or we simply didn't have written processes, were really where we scored ourselves low. So we might be doing something, but maybe we're only doing it in 1 or 2 divisions and not department-wide. And in some cases, we just don't have a formal written process, so we scored ourselves lower. That gives us the opportunity to, correct those and set those as some goals and objectives. And that's really the purpose of the organizational assessment, is an internal document that we reflect on ourselves, make adjustments accordingly. It also sets us up if we do move towards FAB accreditation, that public health accreditation. These are things that we would have to have documentation in place in order for us to meet the standards.
So you're looking for a motion to approve these?
Yes.
Okay.
Can I ask?
Let's do
Should we
the
make the
motion.
motion?
So we need a motion to approve the organizational assessment.
I'll make a motion to approve the organizational assessment.
Second.
Thank you. Discussion?
So what's next then? What would be next with this
Oh, for this, so I think the areas where we scored low in our draft strategic plan, a lot of this stuff is already covered, so we would set goals and objectives there in order to meet those. And then as we move towards FAB, that was one of the things that came out of ISC report, was to shoot for that in the future. So we would put these things in place. The strategic planning, the workforce development, staff development, training, formalized orientation manuals, things like that, that are not currently in place.
And is there a timeline on that potential FAB accreditation?
I think they had it at 5 years. It takes a long time to develop the documentation.
Oh.
It's 369 pages of fun and requirements, the FAB program. So there's a lot to feed in. So we're just starting the process and going what's the low-hanging fruit that we can really get on track here. And thus the organizational assessment that then leads into the training and then the workforce development plan, check, all of these things will check different boxes and requirements throughout the next year or two. So that'll put us closer to the accreditation.
Any other discussion? Darlene?
Mr. Markison?
Yes.
Ms. Parrish?
Yes.
Mr. Clark?
Yes.
Dr. Ansler?
Yes.
Ms. Carmen?
Yes.
Ms. Borowski?
Yes.
Ms. Gaffney?
Yes. Okay, on to the IPLAN approval. Do we have a motion to approve the adoption of the McHenry County IPLAN as part of the application for recertification in compliance with the Illinois Administrative Code?
I move that we
So
approve
moved.
the IPLAN.
Yeah.
You have a second?
Second.
Thank you. Any discussion? Darlene?
Ms. Carmen?
Yes.
Mr. Clark?
Yes.
Mr. Markison?
Yes.
Ms. Parrish?
Yes.
Ms. Borowski?
Yes.
Dr. Ansler?
Yes.
Ms. Gaffney?
Yes, thank you. Budget recommendation, we have the Finance Committee meeting. Kyle, do you want to bring anybody up to speed?
Sure. Obviously, the Finance Committee met and received a presentation on budget requests. There are some supplemental requests. The county has again, as you're aware, requested what's the technical
Maintenance.
status quo maintenance budget.
Mhm.
They don't want any new costs, my understanding. Nonetheless, there is a supplemental request in there for several different things. There's a vehicle,
Some personnel changes.
personnel changes, right? The kennel, I believe, was that part? That was also part of it.
Yes, and we also took out the one of the resolutions in your packet tonight. Oh, are we there yet? Oh, no, sorry, getting ahead of myself. So 8E, the position reclassification resolution, that was originally in the budget that we presented to the Finance Committee. We've taken that out. We're going to push that through the county system in order to try to fill that sooner.
And then additionally, the Finance Committee obviously reviewed the information and spoke about it, and there was an agreement to request an additional supplemental request of funds in the order of $10,000 for employee recognition. We don't know how that will go over, but it's,
Yeah, and
send
on,
that back.
in your packet, it's page 3 of 6 of the full budget, line 404820. This is what has been added since we met with the Finance Committee. There is a main account for employee relations. That is where the 10,000 is. You'll see it all the way over to the right on the supplemental request.
And just for edification, that is to be used to recognize employees at a predetermined date, time, year, anniversary, whatever the administrator decides. With the staff, it would be appropriate.
Right, we're gonna work on an employee appreciation plan that would then have opportunities for, could be what I heard at the Finance Committee, not only recognition for an individual employee, but recognizing all employees with perhaps, a meal or something fun in addition to individual recognition for a job well done.
If anyone's not clear about that, I think we're fairly clear, but make sure we're clear. We're advocating for pay raises. We're advocating for anything to stem the loss of our personnel and to encourage more hiring. And this is one thing that we'd like to also try, because we need to recognize these people that have done great work. Ridiculously underappreciated, and obviously everything we've gone through, it kind of puts it in stark contrast. So this is a small thing that we are looking to the county to support this initiative to further recognize this personnel. I think that we're all clear on that, right?
Mm.
Since you've already added it to it, I don't think we need to vote on it.
No, so now what will happen is this will go to the per your recommendation, right? So we are asking you to vote to recommend it, to move to public health and community services. From there, it'll go to finance, and then, I don't know if it goes to admin services also. I think it goes to finance, then it goes to the CAL in 30-day review, and then approval by the county. I can't remember the date.
Because we have a full board meeting, I think, September
October?
29th. I think we have a full day, or half day, budget day, the end of September, so maybe we can approve in October.
All right, so any other discussion about the supplemental in addition to the budget? Do we have a motion to approve the recommendation of the budget to the county board?
I move to accept
I'll second.
the recommendation of the budget committee with the line item additions.
Thank you. Second. Any further discussion? Darlene?
Dr. Ramsden?
Yes.
Ms. Carmen?
Yes.
Ms. Parrish?
Yes.
Mr. Markison?
Yes.
Ms. Morowski?
Yes.
Mr. Clark?
Yes.
Ms. Gaffney?
Yes. Okay, item E, position reclassification resolution.
Susan, do you want to come? Or do you want? It's pretty straightforward where, so throughout the pandemic, staff got essentially reassigned and we're doing different work. So this is one of those positions that nursing is looking to reclassify from a 6 to a 7 to meet the new requirements on grant deliverables and other work.
Do we have a motion to approve the position reclassification resolution? Dr. Amsler, thank you.
I'll second.
Thank you. Any further discussion?
Just a quick question, is it grant funded?
No,
Is the
this is a
position-
general fund.
This is a general fund position, okay. I was trying to find it. I'm lost in the 759 pages.
I know.
Try doing it on your iPhone, that keeps reloading.
Yeah.
I know that.
And I don't
You keep
have the
going back
fancy
up to the
answer.
top and you're like, so-
Yeah,
So,
sorry, I haven't been
okay.
much discussing because I can't
General
find
fund,
my stuff
okay.
here.
Any other further discussion? Darlene?
Ms. Carmen?
Yes.
Ms. Morowski?
Yes.
Dr. Amsler?
Yes.
Mr. Markison?
Yes.
Mr. Clark?
Yes.
Ms. Parrish?
Yes.
Ms. Gaffney?
Yes. Any other board issues? We have the information and communications, the VFC site visit. Is there any discussion on that? Okay, I do believe we want to go into executive session tonight to discuss personnel. The comment we talked about earlier. Do we have a motion to go into executive session?
I motion to go into executive session.
Second.
Going into executive session at 8:10.
Okay.
How about we?
Take a break?
Yeah.
Yep, she's going to have to switch over.
Got it. Thank you. Thank you, everyone.
Thank you.
No.
No, we just take a pause,
Take
no,
a
we're not,
pause.
we have to come back into regular session. I'm assuming you want me to stay.
Yes.
We can't, most.
Donuts, guys. There's donuts. That's for all of you too.
Yes, because our obesity rate is so low. We need some more donuts.
I can't get your pay. I want your donuts.
That's mental health, that's right.
board that does stuff, okay.
Hmm.
Careful, you're going on the air.
The next campaign slogan?
I will make a motion to exit executive session.
No, we can't yet, she's not live.
She just said she.
Yeah, we're good.
We're good, okay, all right. We have a motion to move back into regular
I'll make a
session.
motion to.
I second.
All in favor?
Aye.
What time is it anyway?
All right, do we have a motion to?
I'll make
It's
a
at
motion to
9:57.
go back into regular, don't we have to go back into regular?
I just-
No, now we have a
It's
motion
9:57.
to adjourn.
Okay, I'll second.
All in favor?
Aye.
Aye.
Thank you.
Thanks, Darlene, sorry.
That's
You were
okay.
stuck here. We haven't done one of these this long since COVID. Come on.
That was my fault, sorry. Joe, let me just say something.
Trust me, I felt the same way.
Do you want me to take it out?